Good evening, everybody. I've been asked to give a talk about headache in pregnancy and puerperium. These are my disclosures. The outline of today's talk will be about primary versus secondary headaches in pregnancy and which medications to use during pregnancy. Headache in pregnancy is very common. It affects about 15 to 20% of pregnant women. There are three possible scenarios when we look at the pregnant woman with headache. The patient suffers from a primary headache and now presents with her usual headache. That's a pretty straightforward scenario. The patient does not suffer from a primary headache and now presents with a first severe headache during pregnancy. Or the patient suffers from a primary headache, but now the pain is different in quality, intensity, or associated symptoms. You can appreciate that in the second and third clinical scenarios, we need to exclude a secondary cause. In a retrospective review of 63 pregnant women presenting to an emergency room with a primary complaint of headache, MRI or CT was normal or revealed non-specific features in 73%. That means it was abnormal, significantly abnormal, in 27% of patients. Among patients with an abnormal neurological examination, 38% had pathological findings on neuroimaging. Among patients with a normal neurological examination, 19% had pathological findings on neuroimaging. Therefore, and we know this as neurologists, a normal neurological examination alone is not sensitive enough to exclude intracranial pathology. In another study that looked at 140 pregnant women presenting with acute headache, 35% turned out to have a secondary headache disorder. Half of these cases were due to hypertensive disorders, such as eclampsia and preeclampsia, posterior reversible encephalopathy syndrome, reversible cerebral vasoconstriction syndrome, or acute hypertensive encephalopathy. Among patients with the primary headache history, the single most feature that suggests a secondary cause is a longer attack duration. What are some of the secondary headaches that we encounter during pregnancy? There's a long list of such headaches, the most common of which include ischemic stroke, cerebral venous thrombosis, pituitary tumors. Choriocarcinoma is supposedly a common finding, although I have never come across such finding during pregnancy. Eclampsia and preeclampsia, of course, RCVS, idiopathic intracranial hypertension, particularly in the second trimester onwards, and subarachnoid hemorrhage. It is beyond the scope of today's talk to go into detail about all of those headache syndromes. So what gives us a clue? There are red flags for secondary headaches, and these include the following: headache that peaks in severity in less than 5 minutes, new headache type versus worsening of a pre-existing headache disorder, change in the previously stable headache pattern, headache that changes with posture, headache awakening the pregnant woman, headache precipitated by physical activity or Valsalva maneuver, thrombophilia, neurological symptoms or signs, trauma, fever, seizures, history of malignancy, history of HIV or active infections, history of pituitary disorders, elevated blood pressure, and recent travel at risk of infective disease. This is all that I will be saying about secondary headaches. And I will address in one slide imaging in pregnancy. Please note that this comes from seminars in neurology from back in 2010. An MRI brain scan without gadolinium is safe in all trimesters in pregnancy, and in fact is the preferred imaging modality to search for structural causes of secondary headaches in pregnancy. You, as I, have undoubtedly come across many radiologists and radiology technicians discouraging their pregnant patients from undergoing MRI and causing a lot of dismay and a lot of problems and a lot of misunderstandings and a lot of back and forth between the radiologist, the technician, and the neurologist. MRI is safe during pregnancy. Now, some people have expressed concerns about MRI in the first trimester. It doesn't pan out. Some have said you should only use 1.5 Tesla. There is no differentiation between 1.5 and 3 Tesla, to the best of my knowledge. A CT head scan without contrast is useful to rule out life-threatening conditions. and is deemed to be fairly safe if radiation exposure to the fetus is less than 1 millirad. And they do use shields, and they do use lesser radiation in pregnant women. So a CT scan of the head only should not be that big of a concern for pregnant women either. So now we've dealt with secondary headaches. Now we will look at primary headaches in pregnancy. What is the natural history of primary headaches in pregnancy? And I think this is a very important observational report with a systemic review on behalf of the European Headache Federation. Headaches change character during pregnancy. If we take a look at migraine without aura, about 2/3 of them will improve during pregnancy, whereas a quarter will remain unchanged. If we look at migraine with aura, we get similar numbers. If we look at tension type headache, over 80% will improve. And if we look at cluster headache, we're back to 2/3 improve and about 1/5 remain unchanged. So there are favorable changes that occur during pregnancy for patients with headache. But there's also, as I mentioned a little bit ago, a tendency for a change in pattern for all these headache types. Migraine with aura can change to migraine without aura during pregnancy and vice versa. There's a tendency to change from tension type headache to migraine without aura as well as vice versa. In one study, 9% of patients with tension type headache developed migraine without aura during pregnancy, while 10% did the opposite. So it's not strange to see a change in the type or character of headache during pregnancy. Migraine without aura can start during gestation in 1% and in some studies up to 10% of pregnant women. Some retrospective data have these numbers up even to 16.7%. And this is classically considered a first trimester phenomenon. Onset of migraine with aura during gestation is reported in up to 10.7% and in some studies even up to 14% of cases. This is, I think, clinically very useful. None of the migraineurs experiencing complete pain remission during the first or second trimesters should experience recurrence of migraine attacks before delivery. So if they've got very good control of their migraines during the first and second trimesters, new onset headaches in the third trimester should make us want to rule out a secondary cause. And postpartum headache is very, very common. It occurs in about 30 to 40% of all women, not only migraineurs. And most of these attacks develop within the first week, but apparently none are on the first day of birth. The pre-pregnancy headache pattern usually restores within about a month from delivery in at least half of the patients, and only breastfeeding and age over 30 retard the headache recurrence. So these are primary headaches. How to manage them during pregnancy? Well, during pregnancy and breastfeeding, the preferred therapeutic strategy for the treatment of primary headache should always be a non-pharmacological one. So what do we mean by non-pharmacological one? Well, we should avoid headache triggers. We should include physical activity in daily routine, manage stress and manage it the right way, practice relaxation techniques, eat smaller, more frequent meals, drink plenty of fluids, follow a regular sleep schedule, and consider biofeedback either privately or by going to a therapist. So the pregnant woman has done all of this and she still suffers a headache episode. What does she do? Well, when she gets a headache, she should rest, lie down in a dark, quiet room with the eyes closed, use compresses, maybe warm compresses to the face, maybe cold compresses to the back of the neck, try massage, and if these steps don't help, then it's time to try medications. Remember, the stress of pain on the pregnant woman may be more deleterious to the child than any medication that we may want to give. Most women, most pregnant women, can safely use acetaminophen or paracetamol. We don't have much data about herbal remedies, and therefore we prefer to avoid those during pregnancy. So let's look at some of the data for acute pain medications in pregnancy. Well, we can think of those in the following categories: paracetamol and acetaminophen, metoclopramide and diphenhydramine, non-steroidal anti-inflammatory drugs, including aspirin, codeine-containing preparations, triptans and ergots, Ditans, and Gepants more recently. If we look at paracetamol and acetaminophen in pregnancy, there have been reports about their use and the presence of adverse pregnancy outcomes. So even with those medications that we consider absolutely safe, there have been reports about adverse outcomes. Two high-quality cohort studies from Scandinavia, one Danish, one Norwegian, suggest, and it's only a suggestion, of an association between acetaminophen use in pregnancy and an increased risk of ADHD-like behavior. And in one of those two studies, there's also suggestion of an increased risk of asthma. How about aspirin? We know that aspirin inhibits platelet function, and this can contribute to maternal and fetal bleeding. Aspirin has not been associated with other congenital anomalies. However, it has been associated with an increased risk of gastroschisis, although this remains unproven. What is gastroschisis? It is a failure in the development of the abdominal wall musculature, and therefore the abdominal contents herniate through this defect, and this requires surgery upon birth. Overall, large trials demonstrate that low-dose aspirin is relatively safe and generally has positive effects on reproductive outcomes. We know that patients who suffer from frequent miscarriages are sometimes put on by their obstetrician low-dose aspirin throughout pregnancy to help maintain the pregnancy. How about metoclopramide and diphenhydramine? I think this is a very interesting study called the MAD headache study. They looked at pregnant women who took a dose of acetaminophen for their headache, and this was ineffective. And then they randomized these women to either IV diphenhydramine and metoclopramide or oral codeine. The primary outcome of the study was reduction in pain score 6 hours from medication administration. Unfortunately, there was no difference seen in the primary outcome at 6 hours, but interestingly, the numbers were statistically significant at 30 minutes, 1 hour, and 12 hours, but not at 6 hours. So the conclusion of the study is that intravenous metoclopramide and diphenhydramine are effective in relieving headaches in pregnant women when acetaminophen fails, and more patients in this MAD group reported full headache relief within 24 hours compared to the codeine. If we look at this data a little bit closer, we can see that full headache relief was achieved by about 2/3 in the combination metoclopramide diphenhydramine group, compared to only about 1/4 of the patients in the codeine group, and the difference was statistically significant at with a p-value at less than 0.05. Perceived relief with one dose, that's a remarkable number, 100% in the combination group versus 2/3 in the codeine group. Who would use the medication again? Many more in the combination group than in the codeine group. Headache recurrence was similar in both, slightly higher with the codeine group, and adverse effects were also similar in both and not statistically significant. How about using non-steroidal anti-inflammatory drugs in pregnancy? Concerns have been raised for the use of these medications in the first trimester and the last trimester. Increased risks of miscarriage and malformations are associated with NSAID use in early pregnancy. Exposure to NSAIDs after 30 weeks gestation is associated with an increased risk of premature closure of the fetal ductus arteriosus and oligohydramnios. If we look at the use of non-aspirin NSAIDs during pregnancy and the risk of spontaneous abortion, in this one study, they looked at 47,000 pregnancies, and they found that 2.6% of them had NSAID, non-aspirin NSAID exposure. Then they looked at 4,700 cases of spontaneous abortion, and in those cases, the percentage exposure to non-aspirin NSAID was up to 7.5%. The use of these non-aspirin NSAIDs during pregnancy was significantly associated with the risk of spontaneous abortion. And you can see the odds ratios for the various agents, diclofenac, naproxen, celecoxib, ibuprofen, rofecoxib, and various combinations, ranged from 1.83 odds ratio up to 3.09 odds ratio. The conclusion of this study was that gestational exposure to any type or dosage of non-aspirin NSAIDs may increase the risk of spontaneous abortion. NSAIDs should be used with caution during pregnancy. Low-dose aspirin is generally considered safe for use throughout pregnancy, and studies have shown that this does not increase the risk of maternal or neonatal morbidity or mortality. And although most non-steroidal anti-inflammatory drugs are likely safe in pregnancy, they should be avoided in the last 6 to 8 weeks of pregnancy to prevent prolonged gestation from inhibition of prostaglandin synthesis, to prevent premature closure of the ductus arteriosus, and to prevent maternal and fetal complications from antiplatelet activity. So many more studies and reviews have been published about the use of non-steroidals during pregnancy. And if we want to conclude, most authorities agree that these agents are relatively safe during the second trimester, but due to the aforementioned reasons, should be avoided during the first and third trimesters of pregnancy. How about the use of codeine? Many studies here look at opiate use during pregnancy. If we look at the 1977 Collaborative Perinatal Project, in this study, they looked at 448 morphine exposures and found no evidence of increased teratogenic effect. In 1992, a case control study of 141 infants with cardiac malformations did not report an association with the use of codeine in the first trimester of pregnancy. In the Michigan Medicaid study of 2002, they looked at 332 newborns exposed to various agents, including hydrocodone, oxycodone, and codeine, all in the first trimester. And the rate of major birth defects was somewhere between 4.6 up to 7.2%. And of course, there was the issue of neonatal withdrawal syndrome. We've always considered that the use of codeine was relatively safe, but now this data shows us that perhaps in the first trimester, there are some reservations. Codeine has been implicated in teratogenicity involving many organ systems. None of these have been substantiated. Codeine use is contraindicated in all people with a known CYP2D6 ultra-rapid metabolizing genetic mutation, or genetic variation, I should say. But how do we know this about our patients ahead of time? So if we want to conclude about codeine, I think it is relatively safe, but best to avoid during the first trimester if possible. So how about the use of triptans in pregnancy? We have registry data for 3 triptans. The risk of major malformations has been reported to be similar to the baseline risk in the general population of about 1 to 3%. And the rates of major malformations in these registries are 4.5% for sumatriptan, which has the most number of pregnancies, 494. Only 2.2% for naratriptan exposure during the first trimester, but this only included 52 pregnancies, and 3.1% for rizatriptans, again in a small number of pregnancies. In the Norwegian mother and child cohort study of 2010, there was no association between triptan use during the first trimester and an increased risk of major malformations. You see the odds ratio of 1 with the confidence interval spanning from 0.7 to 1.2. Triptan therapy during the second or third trimesters was associated with a small increase in the risk of atonic uterus and blood loss, but not with a risk of adverse fetal outcomes. So data for sumatriptan, zolmitriptan, elatriptan, and rizatriptan show no major congenital defects. There's a possible link with behavioral problems referred to as externalizing behaviors with exposure in trimester 1, and they are deemed to be appropriate if the benefit outweighs the risk. No data is available for gepants and ditans, and that's simply because they are new on the market. So after this quick review of all these medications, what should we use during pregnancy? I think most authorities will agree that paracetamol, 500 milligrams to 1,000 milligrams, is safe. Aspirin, low dose, 100 milligrams, is also considered safe, but best to avoid in the third trimester. Metoclopramide, 10 milligrams, is quite safe, and perhaps combining it with diphenhydramine will give additional benefits. Tramadol, 50 milligrams, is also considered relatively safe. If these agents all fail, we can use triptans, and the best data exists for sumatriptan. How about preventive medications? Beta blockers, specifically metoprolol and propranolol, are reasonable during pregnancy if we need to use a preventive agent. We have to look for neonatal bradycardia and hypotension and hypoglycemia when the fetus is exposed in trimester 3. There are concerns about preterm birth, respiratory distress, and intrauterine growth retardation. They're considered first-line migraine prophylaxis during pregnancy. If possible, we should try to taper them off during the 3rd trimester, and we should monitor the newborn that is exposed in the 3rd trimester to these medications. Tricyclic antidepressants have not been associated with an increased rate of birth defects or long-term neurodevelopmental effects, and therefore are reasonable to be used as preventives during pregnancy as well. We should, of course, avoid valproic acid. I think to a group of neurologists, we don't need to explain that. It's quite clear, up to 10% risk of major congenital malformations. In those apparently healthy born babies, there's a net loss of 6 IQ points and maybe some behavioral issues. For topiramate, it's the cleft lip and cleft palate. We should also avoid ACE and ARB type medications. Verapamil can be considered. There are no adverse effects reported from botulinum toxin given according to the preempt protocol and given appropriately. There are no adverse effects reported from nerve blocks, and in this case, we would prefer lidocaine to bupivacaine. Low-dose corticosteroids are considered safe, but should be avoided in the 1st trimester. There's possible early lung maturation with their use early on. Of course, their most apparent indication in pregnancy is in cluster headache and status migrainosus. How about during breastfeeding? Well, a medication is considered safe during breastfeeding if the relative infant dose is less than 10% of the maternal serum level. This is true for sumatriptan and elytriptan, as well as ibuprofen, naproxen, and indomethacin. So if we have to use triptans, it's preferable to use sumatriptan and elytriptan. Sumatriptan, I think it's only 2 or 3% of the maternal dose. For elytriptan, it's something like 0.00 something of the maternal dose. Ibuprofen is safest during breastfeeding, but naproxen and indomethacin are also acceptable. So the risk of adverse events could be minimized by taking medications directly after breastfeeding and discarding all milk for at least 4 hours. With sumatriptan and triptans in general, there's actually no need for the pump and dump approach. Please keep in mind that 15% of pregnancies end up in a miscarriage, and all couples have a background risk of up to 3% of having a baby with a major birth defect. So, should we use MRI? Should we use medications? Well, there must be a well-documented discussion with the pregnant patient about the pros and cons of imaging and use of medication. I hope you found some practical approaches to medication use in women with pregnancy and differential diagnosis of primary versus secondary headache. And I'll be happy to take some questions at the end of this session. Thank you.